Kia ora koutou and welcome to eHealthTALK NZ. I'm Rebecca Macbeth, I'm the media editor at HINZ, and I'd like to thank Third Age Health for sponsoring this podcast episode. Today I'm joined by Chief Technology Officer Sanjeewa Samaraweera and nurse practitioner Elle Dagley. So welcome on the show, Sanjeewa and Elle. Can you start by telling our listeners about your roles at Third Age Health? Sanjeewa?
Hi, Rebecca. Thank you for having us here. My role is Chief Technology Officer. I am primarily looking after anything to do with digital and trying to transform Third Age Health in using more digital tools to deliver better care for our patients.
Great. And Elle?
Hi, Rebecca and Sanjeewa. I'm a nurse practitioner. I work with Third Age Health and provide clinical services into residential aged care facilities across the Auckland region, and also cover on-call to the large number of facilities that are covered by Third Age Health across Aotearoa, New Zealand.
Sanjeewa, what are some of the most interesting potential applications of AI in aged care from your perspective?
With the ability, I guess, with AI to work with large volumes of data, a number of new avenues have actually opened up, especially the ones that I'm very hopeful for are things around ability to do predictive risk management, things like early detection of health issues where you can actually crunch through a lot of sensor data that you would normally not do and use algorithms to predict stuff, and also to have a positive impact in continuity of care. I also think that at the individual patient level, loneliness is a very big issue. And in that area as well, more like a care companion, a lot of possibilities are there. And then obviously in the day-to-day clinical care, the thing that has taken everyone by surprise is the adoption of things like ambient AI tools to do clinical documentation, which is something that's been welcomed by many clinicians.
Yeah, and as a clinician yourself, Elle, do you think AI can support aged care workers and clinicians in delivering better care? And do you have any examples of that?
I do have a number of examples. I'll start with the ways that it can support both people working in residential aged care as staff or also clinicians going in to offer support and review. There's a lot of overlap with the benefits for those two areas of the workforce. Education, there are a lot of AI tools out there or ways that you can use AI like ChatGPT if you give it the right prompts to be able to provide really useful information. I think it's important to be aware that AI has its limitations and that also you need to be aware that, for instance, if you ask for references, sometimes AI will create its own references that don't truly exist. So there are limitations and also risks in using AI, but I think that a careful and ethical use of AI can be really useful in education, not to provide answers to assignments, but more when you're trying to search for information and then you go and use the AI prompts and information to search further to validate it and learn that way. I think in terms of clinical note-taking, it's really useful. There are a lot of clinical note-taking apps available now. Some of them have free versions available. It's really important, again, to use discretion and do your own diligence around checking the notes that it's taken, that they are accurate. Have what I think is one of the most delightful examples of where AI didn't quite get it right, where I was in a general practice setting, not in residential aged care, and I was taking the history for a patient that was sitting with me, and she talked about being a courier driver. AI heard Carrera driver and recorded them as a Porsche driver. So it can get things wrong in quite a delightful but very inaccurate way. So it's really important to do your proofreading. The clinical notes are the responsibility of the clinician, so making sure that you check and correct. But also upfront, before you even start, it's really important to get consent from anybody so they're aware in the clinical setting, if you're using AI within a consultation, to get consent from them. That may be something that is established before they go in at reception or on a case-by-case basis. In residential aged care, it's really important to be mindful of those with cognitive decline who may not have the capacity to give consent, but also those who maybe don't have cognitive decline but have no experience or understanding of AI or computers and simply don't have the information to give informed consent.
So Do you believe then that AI could help older people maintain independence and quality of life at home or in residential care if they do have the capacity to interact with AI or their carers do?
Absolutely. I think that can take two forms, and you've pointed out both of those, that the individual, if they have capacity, then they may access things through their own tablet or smartphone and various other ways that they can access AI. One of the lovely examples is for people who have cognitive decline, actually, and social connection is a vital part of well-being, and isolation is a significant and growing issue for older adults, particularly in the community, but also within aged care facilities where they may have people around them but not really have any connection. There may be people providing care and there's a little bit of contact, but you need that social interaction. And there are amazing AI aids for people who have hearing disabilities or who are visually challenged, but also those with cognitive challenges. There are the video contacts that have the large screens and the direct contact, which keeps people in contact with family when they are more geographically remote.
So Ellie's touched on a couple of the potential challenges or risks there, Sanjeewa, but can you just elaborate on those from your perspective?
Sure, Rebecca. I think the challenge is that the AI advancement, especially around the technologies based on large language models, is relatively very new and advancing at a very rapid pace. So previously, before even these kind of technologies, the divide between, let's say, the technology and its regulatory frameworks and safety frameworks were quite behind. With AI, it's even bigger. The divide is much bigger. So today, the challenge is that most of these technologies don't come with any safety warnings. There's no real understanding of how they actually work. There's also a lot of myths out there. People think that some of these technologies can do reasoning like a human being, which is not the case. I think there is a lot of unintended side effects of using some of even the ambient AI, for example. In the AI industry, we call it the hallucination effect. So this is an example that Ali used earlier. AI can actually make things up that is actually technically or theoretically possible or accurate, but it didn't happen. So most technologies have these hallucinations. So basically, the biggest challenge is to actually understand that there's still a lot of value in using AI. The key is about how do we educate our workforce around the safeguards and the guardrails that need to be there to use it safely. And AI is not a perfect tech by any means, but there's still a lot of value to be derived from it. So it's about putting in those guardrails and safety, and also understanding, especially if you look at large language models, there's a general misconception that everything is based on one model, but it's not the case. There are a lot of different underlying models. So under the hood, it matters how some of these technologies work. Why it's important is that all of these large language models have been trained using a certain training data set. And with that data can come bias. So if these data sets are predominantly trained for demographics that represent, say, North America, there may be gaps in use of that in, say, in the New Zealand demographic context. So there's a lot of different things there, but again, you can still make use of it, but just need to make sure we put in a good framework for that safety.
One thing that someone mentioned actually at our AI summit in May was that the scribes, if people speak slowly, that they will sometimes race ahead and try and predict what the person would have said if they were speaking at a more normal rate. Just wonder among older adults if that's something that either of you have come across or thought about that as a potential issue as they might speak slightly more slowly.
I think the speed can have an impact, but I think if you're looking at it from the challenges in a normal consult context, you need to sort of engage in the conversation in a normal conversation without thinking that the scribe is sitting there, because you're not talking to the scribe, you're actually talking to the patient. So I think sometimes that's part of the training. And one of the things we normally, as part of the early training, is to encourage is to try out how do you behave, how do you use this technology, because you still need to make sure that at the end of the day, when you are in front of a patient, the patient trusts you, not the technology. So you need to make that work. An example that was shared with me in a recent workshop was a clinician was trying to communicate with a patient who English was not their first language. So basically, the clinician used one of these AI tools to write what they wanted to say and ask the tool to translate it. And that actually, bridged the gap in that consult, for example. So I think there are a lot of, what I call secondary applications as well, not just the scribe itself, because sometimes medical words, all of those kind of challenges, health literacy is a challenge always. So I think that clinician needs to adapt based on the patient, and it's just like a normal consult, even without a scribe. Some clinicians will take a different tack based on the patient's level of health literacy and ability to understand the subject.
You talked about it before, Ellie, about the need to respect the privacy of older adults and the unique situations that they might be in. How do you think we can ensure that when we do apply AI in these situations, that their health needs and dignity is respected?
That's a really important area. It's very important to me, and I think every clinician working with every patient of any age. There are particular vulnerabilities for older adults, just as a result of age-related decline, but also the more advanced cognitive decline that can come at that age if they have a neurodegenerative disorder. Particular care needs to be taken in those settings to make sure that we are not assuming that they understand or assuming that they've given consent. So taking the time, possibly at every meeting, because things can change. From if you're doing, for instance, a 3-month review, which is a fairly standard period of review in residential aged care clinically, unless something more acute comes up in the interim. And in that time, people can change significantly. Or if there's an acute condition that makes them temporarily less cognitively capable. So checking in with them at each time and taking the time, I find with older adults, and you alluded to it, Rebecca, with talking about sometimes them speaking slower. They often need us to also speak more slowly and to check in on more than one occasion around whether they understand and whether they're comfortable with the use of AI. I've found very few people of any age are uncomfortable. I've been using it regularly for well over a year, multiple, up to 20 times a day in different settings. And I think I've had maybe 2 people who have chosen to decline. There have been others where there have been older adults where they haven't had their enduring power of attorney with them or have already been assessed to be not capable to understand, and I don't choose to use it in those settings because clinically I feel that I need to make an appropriate choice for them if they've either demonstrated they don't have capacity to understand and consent, or we know that from previous assessments. So that's an important part of maintaining dignity and respect for individuals and their choice and their ability to choose.
And I guess a lot of the claims about AI is that it's going to increase efficiency, and therefore if clinicians have more time, they can spend more time with patients. But do you think there is a risk of actually reducing human connection in care settings by introducing AI?
In terms of clinical note-taking, I don't think so. I think it does free up more time because you're not spending as much time needing to record. You're not needing to look at the computer as often. You can, and I've, as part of my introduction, when I'm using AI in that setting of note-taking and acknowledging the many other applications and aids that are available to support people. But just in looking at something like the clinical note-taking, transcribing and note-taking apps, it saves a lot of time. And I'm a relatively fast typist, but I don't want to be typing while I'm talking to someone. I can type and talk at the same time quite easily at full speed, and that's not a problem for me. But nevertheless, it's actually distracting to the consultation. They've got my full attention, but they won't feel they have my full attention if they can hear me typing away, even if I'm looking at them while I'm typing. So to have something that will do that for me, and then I can just take, a few minutes at the end to proofread, correct, that's much more positive. It does definitely free up time in that aspect. There are a lot of other aspects to care that AI isn't helping with at the moment. So, for instance, processing all your lab results, it can give you some information, but there is a lot of time outside consultation that I haven't found a way to have it reduce my time, but it can increase my quality of care, which I think is really useful.
And you talked about there's various large language models, Sanjeewa, and we don't always know exactly how they've been trained and what biases they might have in them. So how do we tackle that when dealing with a vulnerable population like older people?
Very good question, Rebecca. I think it's one of the hardest areas the sector is and the industry as a whole is facing. At the moment, I think there are no simple answers there. And I think part of this is that test we need to apply, which is the ability to understand how these models are developing answers. So the issue of transparency comes to light, and also explainability. The day a clinician needs to be able to explain in plain English or understand how it arrived at a particular conclusion or decision or recommendation. I think the only thing is that at the moment, because most of these tools are just out of the labs and being used, there's no real frameworks as such for addressing these issues. So I think what we need to do is to basically start at the beginning by educating the workforce when they're using these tools, the actual existence that there's going to be a level of bias and ethics and all of those other issues that come with it. So we need to raise the awareness, and we also need to start doing some audits as well, from seeing, okay, how is the data? What can we see? I mean, we can do a lot of work initially to do some sample testing to see what does the models behave, what does it, even if we don't know how it's doing the actual reasoning or reaching its conclusions, we can actually test with certain scenarios and see whether it's safe or not. And that's where we need to get into the habit of explaining the disclaimers. It is not going to work for these scenarios. So clinicians are very clear that, okay, these are the current limitations, and these technologies do have limitations. They're not widely publicized, but we need to do a much better job at making sure our clinicians understand the limitations. And then we need to also build in processes outside of the use of the tool where we can actually monitor. One of the things that most people I hear say is that after you put the tool in, the tool will correct itself. That's another myth out there. It doesn't fix the bias that is there in the training that's been done. So you need to build processes outside to do continuous monitoring and see how it's responding. Without those process framework wrap around it, you're going to expose yourself to quite a lot of risks and limitations that come with these tools. And I think the other thing I hear a lot is that these AI tools will say there's a human in the loop, so there's not much to worry about. But that's also a huge burden to put on the individual clinician, but it's very not a fair ask in my view.
So moving on to the enablers of AI, as you were talking about, it relies on data. So AI is not going to work on paper. We know that much of aged care is still on paper. So how important is it first to have the fundamental digital systems in place, and then to have good enough data quality to actually build effective AI tools in the aged care sector?
So I think if you look at the type of AI tools we're using more around generative AI, like ambient tools, data quality in our data systems, don't have a huge impact. But as we start to use AI for other things like algorithms, prediction, risk management, the quality of the data, the coding of the data all becomes extremely critically important. And AI is only going to be as good as the data and the data quality. There's going to be a very strong link between the two. And I think if you look at today where we are in AI, the most advanced field probably in the use of AI in healthcare is probably in image recognition, pattern matching, in radiology, those kind of fields, mainly because they've been able to train a lot of that technology with millions and millions of data input points. Whereas if you look at some examples like patient clinical records, or the data quality coding standards vary, so it's going to become very challenging. So I think this is going to be while it has a huge amount of promise, ability to make the most out of it will come back to how good is your data. You can say, it's like garbage in, garbage out. So I think that's where I think we'll have to start to adopt much better data practices to actually manage this and make sure the use of standards becomes far more fundamental, which has been lacking up till now. So a huge change will need to happen in the healthcare industry in terms of improving data quality if it wants to really benefit from the advances that are possible in AI technology.
Yeah, and when it comes to standardization and use of systems, what role, Ellie, do you think government should play around policies and shaping the responsible adoption of AI in aged care?
That's a really interesting question. I think there are a number of areas where policy is vital in safeguarding the quality of AI. Policy can guide where people access AI, what's recommended. It can also provide information and guidance on how to use it and limitations on where it isn't appropriate. Hopefully, clinicians and care workers in any healthcare setting would be aware of their responsibilities and boundaries and use it appropriately. However, I think that having a framework that guides the use and would also guide the amount of information and understanding that a person needs in order to use it safely and appropriately. There is a big gap there at the moment. There's quite a lag behind what's available and what people are accessing, and any kind of framework or policy out of government to guide and manage that to keep it within safe boundaries.
As I said earlier, the challenge will be the pace of change that's happening in AI. Regardless of how fast AI advances, I think we will need to think of a new kind of a policy and a regulatory framework to deal with AI, because you can't afford to wait 12 months for a policy document, or you could have 3 generations of AI changes happen by that time. So policy has its place, but I think we need to relook at how we look at policy and regulatory frameworks, and we need to build it around how do we make this safe, how do we build the guardrails, and also how do we make sure that there's transparency, mandatory reporting. I think that kind of frameworks are required, where just like some of the good practices we see with privacy frameworks that have now matured after many, many years, we need to have similar voluntary reporting frameworks. But we just need to also be realistic that the traditional way of doing policy and regulation in a world of AI will become extremely challenging, and it's not going to serve any valid purpose. So I think we need to really say, okay, knowing what we know about how AI is changing, understanding where the risks lie, we need to probably adapt a brand new framework. I totally support that we need strong policy, because at the end of the day, we want to make sure the technology is used correctly, people are getting benefit, patient safety is paramount. And ultimately, we only look into these technologies to enable us to make our life better and deliver better healthcare and better health outcomes and make it safe. So it needs to be safe for all parties. It needs to be safe for clinicians to practice and use these tools. And it needs to be extremely safe for patients as well. And so I think it needs to have that balance. Some of the frameworks we have today does not suit this kind of technology.
Yes, it will certainly have to be very sort of agile and flexible, won't it, and able to adapt as things change. So, as you said, the point of all of this is to make things better ultimately for clinicians and patients. So finally, if each of you had to pick one area where AI could make the biggest positive difference in aged care over the next, say, 5 years, what would that be?
5 years is a very, very long time. And if I was to pick one, it would probably be the area around independent living. I think we have to face the reality around some of the economic challenges we have around aged care beds, and people will want to live independently longer at home. So I think AI potentially has the ability, if you look 5 years, to make a huge impact there. That's my hope, that that's where the difference can happen. Between now and then, it will certainly have many applications around some of the things we talked about, and algorithms and stuff like that. But I think you're already starting to see today robots coming out. We have robots that are able to make coffee. We have robots that are able to do care work. So I think, in 5 years' time, supporting independent living, making sure people are safe, making sure you're collecting large volumes of sensor data, a lot of possibilities exist. So that's some of the things that are possible.
I agree. I think that, the importance of optimizing the amount and quality of care that real people can provide is really important, because AI can help with a whole lot of functional tools, and it needs to advance further in that space, because the one thing I think that we have, like AI cats and things like that can act as companions, they go a certain amount of the way and they do make a difference. They do make a difference. The AI companions are useful. I don't think they will ever replace human contact. So the more AI can help in the areas that means that quality contact and the real world person-to-person contact can be maintained with people in the community will be the biggest thing that will make the difference between delaying them requiring the more expensive residential aged care input. And so all the AI tools that can aid with any of the age-related decline and loss of abilities, whether that's mobility or sensory abilities, all of the things that AI can step up into that space more and more and more will make a difference to giving more space. And the risk, I think, with that is that then people go, well, that's all being looked after, so they need less time. The social isolation part is the part where we need that human contact to be optimized. And AI can help in that space too, through things like video connections, smart audio connection, things like that, that will help people who can no longer dial numbers or have difficulty hearing or seeing or understanding how to contact and reach out. AI can help in those spaces, but I think addressing the social isolation that drives a lot of the decline that leads to costly care is a big space where a difference can be made. I look forward to seeing how that will look in 5 years' time. I think it will be quite a different world in 5 years' time.
So do I, yes. It's a very difficult future to predict at the moment, but I like that you've both got a positive view on what it might do, and that, ultimately it's about improving patient care and giving back time to care. So thank you so much for joining me today, Ali and Sanjeewa, and thanks to Third Age Health for sponsoring such an insightful podcast episode. If you want to learn more about Third Age Health, you can visit the website at thirdagehealth.co.nz. Mā te wā.